Alright guys, let's get busy talking about androgen modulators. Now, when it comes to androgen modulators, there are a variety of indications for these drugs, ranging from prostate cancer to breast cancer to male pattern hair loss. And so there are going to be a number of things we need to know about how they operate and where they operate throughout the body. Now, when I was studying for step 1, I always found androgens to be a very nebulous topic. I feel like they're never well explained during medical school and they're never well defined. So I want to talk you guys through where androgens are made and where they exert their effects, and also the names of our androgens as well. So I want to orient you guys to this slide, and we're going to walk through androgens at baseline and talk about them a little bit, and then we'll get into some of our agents. So in terms of this diagram here, all of our red agents are going to represent agents that are going to antagonize androgen activity. And then our green agents are going to be those that are going to agonize or promote androgen activity. And then to further orient you guys, here we're talking about the adrenal cortex. So the adrenal cortex, as you know, is responsible for making steroid hormones, and androgens are examples of steroid hormones. And then we're going to be talking a little bit of our HPA axis, and then also peripheral tissue like the testicles, and then also androgen receptors, which are going to be located throughout the entire body. So this is just kind of our overall schema to orient you guys to what we're going to be talking about in terms of androgens. So let's go ahead and orient ourselves to the 4 androgens that are going to be important on step 1, and that's going to be DHEA, androstenedione, testosterone, and DHT. And androgens, in terms of a definition, are just going to be chemicals that promote masculinization. And so the classic androgen that we think about is testosterone. And the rest of our androgens have very similar activity. They're just in slightly different forms and may have their effects or be produced in slightly different areas. So for the sake of this video, I'm going to put a brown box around our androgens that we're going to be talking about, because this is where our drugs are going to have their effect, either in the cortex itself or in the testicles or in the periphery. And so there's an important relationship when we're talking about the peripheral tissue and our androgen receptors and our HPA axis. These are all going to play together when talking about androgen agonism or antagonism with these therapies. So now that we're oriented to where our androgens exist in this overall schema, let's talk about some things that come before androgens. So cholesterol is going to be like the daddy precursor of all steroid hormones, and it makes a lot of different precursor molecules along the way before it becomes androgens. And then there are also some offshunts to become mineralocorticoids or glucocorticoids that we're not going to talk about in this video, but I just want you guys to be aware that this is a very dynamic process in flux as we transition between different forms of steroid hormones. Now, additionally, androgens, which are steroid hormones, can go on to become estrogens. So after they become androgens, they can go on to become estrogens like estrone and estradiol, and this is going to occur via the enzyme aromatase, which we see sitting here, and this is going to be the enzyme that is the target of one of our pharmacologic therapies. And then at the end of the day, all of this is going to agonize our androgen receptors that are located throughout the body, in the breast, in the prostate, in the skin. Pretty much everywhere throughout our body we have receptors for androgens. So now that we've oriented ourselves to our diagram, let's go ahead and get into some of our agents. The first agent that we're going to talk about is going to be our aromatase inhibitors. And the mechanism of action here is going to be aromatase inhibition, and aromatase is the enzyme responsible for converting androgens into estrogens. So we're going to see decreased peripheral conversion of androgens into estrogens if we are inhibiting the enzyme aromatase. So let's take a look at where this lands in our diagram. If we zoom in here, we can see that our aromatase inhibitors are going to be in this central part of our diagram. Here are our 3 aromatase inhibitors: exemestane, anastrozole, and letrozole, and essentially they're going to be inhibiting aromatase here, and this is going to lead to increased levels of androgens like androstenedione and testosterone, and reduced levels of estrone and estradiol. And this is going to be really helpful in our patients who are experiencing estrogen receptor positive breast cancer. We can use agents like anastrozole, letrozole, and exemestane to treat these breast cancers because they are sensitive to estrogen. So if we can reduce the amounts of estrogen and keep those estrogens as androgens by inhibiting aromatase, this is going to be therapeutic for patients suffering from these types of cancers. In terms of some adverse effects, we can expect to see hot flashes, sweating, and weakness. Now, Now, let's move on to talk about danazol, which is going to be our next agent, and this is going to be a synthetic androgen. So this is going to be an androgen that is chemically created in a lab and then given exogenously to a patient. And so a synthetic androgen, and it's going to act as a partial agonist at androgen receptors. So this is not going to be involved in the adrenal cortex or the testicles at all. We are just going to give danazol, which I have here, as a synthetic androgen. We're just going to give it to a patient exogenously, and it's going to exert its effects at androgen receptors throughout the body. So this is a relatively simple mechanism of action. This is just a synthetic androgen that we give exogenously. And we can use this for endometriosis. And the reason why this is helpful for endometriosis is because endometriosis is uterine tissue that is not in the uterus anymore, and this can grow with estrogen and become really painful. And so if we give androgens like danazol, it can shrink this tissue and make it a lot less painful, which is going to be helpful for our patients. It can be also used for hereditary angioedema, which is related to C1 and the complement cascade, and it's going to change the balance of complement proteins and help these patients with hereditary angioedema. And then finally, it can be used for leiomyoma, which is also called fibroids, because these are hormone-sensitive tissues as well, and it's going to help inhibit some of that estrogen effect that normally makes these tissues painful. In terms of adverse effects, they're going to be all related to increased androgen agonism. So weight gain, edema, acne, hirsutism, masculinization, these are all the classic symptoms of, I think, of someone who's on exogenous testosterone, like an anabolic steroids bodybuilder. They're just going to be big, they're going to be bulky, they're going to be masculine, they may have voice deepening. These are effects that you would expect to see in a patient taking danazol. We can also see decreased HDL levels, hepatotoxicity, and idiopathic intracranial hypertension. This is kind of like a sneaky side fact that they like to quiz about patients who are on danazol. All right, so let's move on to our last agent on this slide, which is going to be testosterone or methyltestosterone. And this is going to be very similar to danazol, except instead of being a synthetic androgen, it's going to be a naturally derived androgen. So they make this testosterone in plants like yams and soybeans, and they extract it, and they essentially inject it into humans, and it carries out the normal effect that testosterone would do that was created either in the testicles or in the adrenal cortex. So let's take a look at where this fits into our diagram. It is literally the same as naturally occurring testosterone, which is right here in our diagram. However, we're giving it exogenously, so it's just going to go directly to the androgen receptors located throughout the body. What we can use this for is hypogonadism. It's going to be an agonist at androgen receptors. So if we have testicles that have atrophied or are no longer working, we can go ahead and supplement that with testosterone that is given exogenously. However, I want to note that giving testosterone exogenously is not going to actually treat the hypogonadism. So patients who are receiving exogenous testosterone, we're essentially doing the job of the testicles for them. So the testes are like, peace out, we're done working, we're not going to make any more testosterone because we're getting it exogenously. So this will treat the symptoms of hypogonadism, but it will not treat the hypogonadism itself. And that's an important distinction when thinking about exogenous testosterone administration and how in patients receiving exogenous testosterone, we can expect to see smaller gonads. And that's pretty interesting. And then additionally, we can use this for promotion of secondary sex characteristics. We know that androgens are what promote masculinization, so if we can give exogenous androgens in the form of testosterone, it can help promote secondary sex characteristics in patients that need that. And then it's also going to be able to stimulate anabolism. We think of anabolic steroids as making people really buff and growing a lot of muscle. This is what testosterone is great at, and it can also help promote recovery after burn injury. Now, in terms of some side effects, it's going to be very similar to danazol. We're going to see masculinization. We're going to have decreased testicular testosterone production because this exogenous hormone is doing the job of the testicles for them. And then we can see premature epiphyseal plate closure in our young patients, increased LDL, as well as decreased HDL. So this is the wrap up of our agents that are all going to cause agonism of androgenergic effects. In the next video, we're going to be talking all about anti-androgens, so be sure to stay tuned for that, and I will see you guys in the next video. Bye!